So welcome everybody to this panel discussion on pathogen sharing in the context of pandemic preparedness. The pandemic has highlighted, of course, the importance of sharing pathogens and their genomic information swiftly and widely, and the impact it can have on helping the world face future epidemics and pandemics. And as governments negotiate the details around a potential new global instrument to improve how the world should prepare and respond to future pandemics, it's critical that they consider the unintended consequences of international environmental agreements meant to preserve the world's genetic resources. I'm talking, of course, about the Nagoya Protocol of the Convention on Biological Diversity. A first condition of pandemic preparedness that considers human health and biodiversity is pathogen sharing. So this session, we're bringing together scientists and experts to discuss the importance of unrestricted pathogen sharing in the context of this and future pandemics, as well as sharing experiences on the negative consequences of the Nagoya Protocol and the convention that it can have on public health. So we are first going to be watching a video which explains the challenges with the Nagoya Protocol, and that will set the scene for our discussion. Each of our panelists will share their experiences and their insights, and then we will move to audience Q&A. So if you'd like to ask a question when the time comes, please raise your hand, and when I call on you, please say your name and your affiliation before you ask your question. Okay, thank you. We're going to watch the video now, so please enjoy.
The Convention on Biological Diversity is an environmental treaty that came into force in 1993 with three main goals: conserving biological diversity of plants, animals, and microorganisms, the sustainable use of biodiversity, such as soil, water, and living organisms, and the fair and equitable sharing of the benefits that can be derived from using genetic resources. In 2014, a supplementary agreement to the convention called the Nagoya Protocol came into force. The Nagoya Protocol offers guidance for developing national access and benefit sharing, ABS, legislation for countries that choose to have this type of legislation. So what does this mean in practice? Let's look at a hypothetical example. Under the Nagoya Protocol, a company developing a cancer drug based on a molecule extracted from a tropical tree should share any benefits coming out of commercializing the cancer drug with the tree's country of origin. And this is a good thing. While the objectives of the convention are unquestionably fair and right, the implementation of the Nagoya Protocol has had unintended and undesirable consequences for global public health. A key issue in this regard is the application of an ABS framework to pathogens impacting human health. Many countries have included human pathogens, such as polio, Ebola, coronaviruses, or influenza viruses, in the scope of their ABS legislation. This leads to delays and prevents sharing of samples and data on pathogens that are crucial for fast research and vaccine production. However, pathogens are not ordinary genetic resources, and they certainly shouldn't belong to one country. The COVID-19 pandemic has demonstrated that pathogens know no borders and pose a common global threat to all countries and to all people around the world. No one wants to preserve the biodiversity of dangerous viruses and bacteria. Quite the contrary. When fighting infectious diseases, we need to share pathogens and their genetic information quickly to scientists around the world. This is critical because diseases need to be tracked, new variants need to be identified, and we need to predict how diseases spread. Scientists and other experts around the world need to start working together to rapidly develop medical countermeasures such as vaccines, medicines, and diagnostics. Unfortunately, in spite of the Nagoya Protocol's provisions for health emergencies, some countries implement the Nagoya Protocol with no consideration of global public health and the need for the rapid sharing of pathogens. What started with best intentions to protect biodiversity has become extremely dangerous and detrimental for pandemic preparedness. As such, in many cases, national ABS legislation has slowed the process of accessing and sharing pathogens. It can take months or even years to negotiate complex bilateral contracts, preventing the quick response needed to tackle epidemics and pandemics. What's more, some countries are not sharing their viruses and bacteria with the scientific community for disease surveillance, epidemiology, or academic research, because countries see this information as a potential source of income, while at the same time, freely accessing the genetic information shared by scientists in countries with no such constraints. The Nagoya Protocol has led to confusion, especially among scientists. Countries interpret it in different ways, creating significant barriers to scientific progress. COVID-19 has shown the undeniable need for international cooperation and a universal commitment to a data and pathogen sharing system that is open and freely accessible for all. Just imagine what would have happened if scientists had not shared the genetic information of the new coronavirus with the whole world in early 2020. The biopharmaceutical industry urges governments to find a solution nationally and internationally to allow timely and unrestricted sharing of pathogens, a crucial step in preventing and mitigating the next pandemic.
So I think that gives quite a good context to our discussion today. So I'm going to ask the panelists to please return to their seats. We're a bit out of order with Thomas sitting over there, but it's fine. I can manage. No problem. In the naughty chair over there. So our first speaker today is John Macaulay, who is Director of the World Influenza Centre at the Francis Crick Institute in the UK. And John, I'd like to ask you to kick off with what is the current system for sharing pathogens, such as influenza, and what challenges are affecting its sharing?
Thanks very much for the invitation to speak here today. It's really good, and it's really nice to see the audience here. I think that some of the points have been really nicely made in the little video that we just saw here. It's been remarkable, really, what's happened during this coronavirus pandemic. I mean, the information and virus sharing, particularly the information sharing, has been pretty spectacular. The next generation sequencing has dramatically changed the amount of data that can be shared so rapidly. As counting at the end of last week, there are over 10.5 million viruses in the GISAID database for SARS-CoV-2, which makes me look at influenza thinking that we did pretty well at about 350,000 virus sequences for influenza. But we thought we were doing well, but that was it. But that's just information sharing. And I'm going to focus particularly here on influenza and illustrate it's an old system that still is there and develops. And in fact, the data sharing mechanism for the SARS-CoV-2 genetic data is based on GISAID, which was originally developed for sharing flu sequence data. So the threat of influenza is pandemic and seasonal, and of course, pandemic preparedness. And so we have to be able to assess all of these things. And the urgency in a pandemic is probably the same as the urgency for an update of a seasonal influenza vaccine. A new seasonal influenza vaccine can go around the world in less than 10 months. This is the same sort of equivalent speed as a pandemic virus would go around the world, so that the urgency is still there. So what is it that we need? So we have fair and easy, relatively easy sharing of gene sequence data, but from that we don't know all the properties of the virus. We can't predict many of the properties of the virus, and this is what we need for the pathogen to be shared as well. And so what we can't do, for example, is to predict the antigenic properties of a virus in order to make a vaccine solely from the gene sequence data. We need some measurements to back up what we think is happening. We need a hands-on that vaccine for seasonal influenza vaccines, and also for risk assessments, in particular for pre-pandemic vaccine generation and prioritization of development of vaccines for pandemic preparedness purposes. For influenza, this is done through WHO Global Influenza Surveillance and Response System, which actually started in 1948. The first global surveillance, virological surveillance of influenza started from a laboratory in northwest London in 1948. And it's developed since then. Now there are, 147 national influenza centres around the world in 115 or so member states. Though the activities there are not coordinated, but sort of put into a global context by WHO collaborating centres, and the Francis Crick Institute hosts one of these as the Worldwide Influenza Centre. And there are 7 WHO collaborating centres around the world, 5 on seasonal influenza viruses and 2 on viruses at the animal-human interface. For our centre, the last year in which we had a full set of viruses coming in was 2019. We received viruses, about 5,000 viruses, from 90 centres around the world. So this is the largest number of all the collaborating centres that deal with that. But 95% of our viruses come in from countries not within the UK. And so those are critical that we receive those. And we have to be able to receive these in an open and simple way. So it's urgent as well. For vaccine development, we work backwards. The vaccine needs to be given in October. It needs to be ready to be shared, to be distributed in September. It needs to be balanced and produced. And so we have to make a recommendation in February. In order to make the recommendation in February, we've got to have developed the viruses. That if it's going to be a new virus, we have to have done that in December or November, December, January. This is hard times. This is urgent. And for that, we need rapidly be able to go through any protocols that we require. So that's the urgency. Now, this is focused somewhat on the pandemic. I've been talking about seasonal there. The pandemic timelines will be the same or faster. But for the pandemic, let's talk about pre-pandemics. We make risk assessments of potentially pandemic viruses. Why? Because actually we're going to make pre-pandemic vaccines, and we're going to prioritize those. They'll be from zoonotic infections. A lot of the information that we would get is just information, gene sequence data, where it is, what animal species it's in, and various other parameters. But there's population. But there are various features that you do need to know. One parameter is how well does this new zoonotic virus transmit in animal models? For that, we need the pathogen. What's the receptor binding specificity of the new virus? For that, we need the pathogen. We need to know if it binds to human receptor better than it binds to avian receptor. We need the pathogen. We can't predict that. We need to know the susceptibility of antivirals. Well, there are hallmarks for susceptibility, but we need to test them as well in case there's something new that we don't know about, because that's going to affect how you're going to respond to a pandemic. And finally, we need to know whether or not there's background immunity to this new virus in the population. And for that, we need the virus as well. So there is under two hands, we've got the gene sequence data and all of that kind of stuff to be shared, and we need the pathogen as well. And so what we have to do here for SARS, flu, SARS-CoV-2, we need open data sharing, information sharing. But we also, for detailed analysis, we must have, such as the antigenic properties and those other properties, we must also have the virus itself to be able to do this in a reasonably efficient way. And this open sharing of both the information and the pathogen benefits us all.
Thank you, John, and that was well within time. I didn't have to raise my 3 fingers. So our next speaker is David Heyman, who is a professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. He is also former head of the Centre on Global Health Security at Chatham House. And David, if you could please address who are the actors that need to be mobilized and what are the instruments that need to be put in place to ensure that the scientific community has unhindered access to the pathogens and the information, the genomic information, for the development of vaccines, medicines, and diagnostics.
Well, thanks, Emma. And thanks also to the IFPMA for having invited me. Actually, this assignment from the IFPMA has made me really think back to many different experiences that I've had in my career. And I'd like to share some of them with you, starting off by saying that the polio virus, though it doesn't spread like influenza, is an RNA virus, and it has the same type of mutation as do the influenza viruses, and they must be monitored. In fact, each polio virus has its own identity and permits tracing the virus to its unique ancestral polio virus that was isolated previously from a person with polio. This not only tells from whom the virus has come, but also where it's come from. And this geographic location then permits a response by the polio eradication program to an area where the virus has originated, which may not have been identified through routine surveillance. And I might add that, like the influenza system, this system continues to function despite concerns globally about privacy of data and the lack of a global standard for data sharing, ethics, and privacy. Polio surveillance is not only in humans, however, it's also in the environment, in sewage. And this is where the geographic origin is also very important. A good example is in Mumbai in India, towards the end of the elimination efforts in India. Mumbai was polio-free in the early 2000s, but environmental surveillance in the sewage continued to show that the virus was present in Mumbai, and it was actually coming from other states into Mumbai. And by that genetic sequence, the information could be obtained as to where that virus had come from, and the community where it originated was then targeted for activities. And as you know, efforts in eradication in polio in India have now resulted in interruption in transmission. The database that's underpinning this global surveillance activity and the tracing of virus origins was maintained by several global collaborating centers, just as for influenza with their global collaborating centers. And these centers have the capacity not only to store the virus, but to do the genetic sequencing necessary. But when polio eradication program missed its target in 2000, it was necessary to identify reasons that that target was missed. This problem was eventually overcome, but the global collaborating, this required modeling by some experts in modeling to help understand where and what in fact the problems were in eradication. This required access to the global databases that were being held by the collaborating laboratories, but these global collaborating institutions did not want to share their data with the modelers. And the reason had nothing to do with the Convention on Biological Diversity, with ethics and privacy concerns, or with the Nagoya Protocol, which had not even been put in place at the time. This was the scientists who had accumulated and maintained the database. This was a rich resource for their academic publications, and they did not want to share this data with other scientists. The problem was eventually overcome and the modelers were given access to the database, but it's illustrative of one of the many reasons that sharing does not occur: failure to share pathogen information within the scientific community itself. That's one of the major stakeholders in pathogen sharing. I'm not going to meet your time limit, Emma, I'm sorry. Fast forward to 2003. Early in the SARS outbreak, when there was an urgent need to understand the cause, scientists from several different countries had isolated the virus and successfully sequenced it. Delays in sharing the data while awaiting publication could have occurred. But one of the scientists decided to share the data before publication. This was welcomed by countries around the world, and not only did it facilitate the response to the outbreaks, but it also had led to an eventual declaration by medical journals that they would accept for publication information that scientists had placed in the public domain if this was done in the same public health, in the efforts of public health as had been done for SARS. Medical journals are stakeholders as well in data sharing, and as we know now, in the current pandemic, they're sharing information and rapidly peer reviewing it rapidly and putting it out on the World Wide Web in front of their paywalls so that everyone has access. These two examples, polio and SARS, show the importance of sharing sequence information in a searchable database. And with MERS and SARS coronavirus 2, we've again seen how important it is for early sharing of sequence information. By sharing of data on a newly identified coronavirus, the MERS coronavirus in Saudi Arabia in August 2012, the diagnosis of a patient who had traveled to the UK in the following month was rapidly confirmed and an outbreak prevented in the UK. And from the initial release of sequence information early in the COVID pandemic, as we've heard, rapid development of next generation polio vaccines could begin. But these prototype vaccines required the virus as development continued in order that the essential animal model challenge studies could be done, as we heard from John earlier. So in this pandemic, the virus was abundantly available for research in all countries. The pathogen had actually been shared around the world by globalization. But that's not true for many other viruses, and we have to make sure that we understand that. But one last point is, when countries have freely shared sequence information about variants, many times they were accused of being the source of the variant, and travel bans were put in place that damaged their economies. The governance mechanism that had been established to prevent this, the IHR, was not used. Countries preferred to use their own information, and that information in front of paywalls of the medical journals in order to do their own risk assessments and mitigation. So the IHR, a tool that was developed to prevent issues involved in global travel, was not respected by many countries. I won't continue with examples of this except to come to one more. And this is that the private sector can contribute to sharing as well. We need to move past the idea that the private sector is to be excluded from discussions on pathogen sharing. An example why this is important comes from those companies that constantly monitor pathogens and chemicals in water so that drinks and other products produced are safe and meet quality norms. Another example is the pharmaceutical companies that monitor the isolates of bacteria that are resistant to the antibiotics they've developed. Sharing in global databases has begun from this private sector as well and must continue. So Emma, the answer to your question about who are the actors that need to be mobilized and what are the instruments they need to put in place to ensure the scientific community has unhindered access is not a simple answer. It involves many different stakeholders, scientists themselves, medical journals, pharmaceutical companies that develop and produce vaccines and monitor the effectiveness of their antibiotics, private sector that monitors systems such as water systems for safety, best practice consensus frameworks for ethical sharing of pathogens and information, transport systems, because it's important that virus also be transported, and many times the transport system refuses those organisms, and the willingness of countries to adhere to globally established mechanisms such as the IHR, the PIP framework, and the COVAX facility, or to use lessons from them to negotiate a new way forward. Thanks, Emma.
Thank you, David. And in the end, we only lost 1 minute because David used up some of John's time that he generously devoted to David, and I guess worth waiting for to finally get an answer to those questions. So, okay, I guess I'll get over that. Moving on to our next speaker is Jacqueline Castile from the Global Nagoya Protocol and Global ABS leader from the drug maker Boehringer Ingelheim. And Jacqueline, we're going to move now into the relevance of animal health research. And Jacqueline, if you could address, is the One Health approach, and specifically animal health, being adequately considered in pandemic preparedness and response efforts? And anything else you think is relevant to this discussion?
Thank you. So, ladies and gentlemen, it is a privilege to be here today, and I would like to thank again the EFPMA for organizing this event and for giving me the opportunity to take part to it. I'm leading the Nagoya Protocol, an access and benefit sharing initiative for the pharmaceutical company Boehringer Ingelheim. Today, I will, however, focus on the essential role of animal health in pandemic preparedness and the difficulties we are facing in this area. Animal diseases represent threats to the environment, animal welfare, public health, and have important social and economic repercussions. When the animal-human barrier is passed, epizootics become zoonoses and constitute real menaces for human health, with varying morbidity and mortality rates, for example, avian flu, Ebola, Lassa virus, and of course, COVID. Zoonoses are extremely abundant, and it is essential to consider them in pandemic preparedness. According to the WHO, 60% of the human infectious diseases are zoonotic. 75% of the human infectious emerging diseases are zoonoses. Outside of the current COVID pandemic, zoonoses affect each year 2.4 billion of humans worldwide and generate 2.2 million of human deaths. Change of the biodiversity, which is today unfortunately a reality, increases the sanitary and emerging risks of zoonotic infectious diseases. Threats are real. We must be prepared. What can we do? First, manage each contamination link of these diseases in order to block viral offensives. Animal vaccination is clearly an efficient way to prevent the spread to humans. Second, anticipate each type of pathogen emergency. The aim is to closely monitor and detect in order to better anticipate and adapt to virus evolutions. So, what is my reality today in Boehringer Ingelheim? On the one hand, I'm super proud of the internal system we have put in place to address Nagoya Protocol and access and benefit sharing compliance. On the other hand, I'm super frustrated not being able to find simple solutions and concrete support to provide my research and development teams with the genetic material they need to successfully complete their mission, health protection. It is more and more challenging for us to be able to update our existing vaccines, to develop new ones, and to continue to innovate, particularly on emerging and transboundary diseases. The Nagoya Protocol, while based on laudable principles of fairness and equity, has made cross-border collaborations involving genetic resources incredibly difficult to implement. The complexity, heterogeneity, and sometimes unclarities of national access and benefit sharing legislations, administrative procedures, and enforcement policies are additional complications. Last but not least, the misreading of animal health diseases and associated research and development activities by some Nagoya stakeholders is another additional problem for us. Alternative in conclusion, One Health is a fantastic concept, which will definitely enlarge and improve the scientific knowledge sharing, thus creating synergies between human, animal, and environment sectors to achieve optimal health outcomes. Now this approach has been well defined. It has to be translated in more concrete measures at a global level. Pandemic preparedness and response efforts to be effective and agile if and only if a fast, easy, and clear access to pathogens is possible, and animal health should not be forgotten, as this is the entry point of the viral disease control. Thank you for your attention.
Thank you, Jacqueline, for that amazing description of the importance of One Health and zoonotic spillovers. It seems is a rather neglected area. We are moving on now to our next speaker, who is Thomas Cooney, Director General of the International Federation of Pharmaceutical Manufacturers and Association. Thomas, hoping you can address how we can reconcile the public health objective of eradicating pathogens for the protection of public health and the Convention on Biodiversity objective to protect biodiversity. I mean, can open access to pathogens and their genetic sequences help us to prepare for a pandemic, and how?
Thank you very much, Emma. And first, of course, my apologies for having been a naughty boy and rocked your seating order. I was on the COVAX coordination meeting, and that's why I was a little bit tight in time. It's also why I put on my tie, because having watched Seth Barkley wearing a tie, which is highly unusual, I thought, oh my God, I better get properly dressed for this important event. In terms of your question, basically the answer, I think we first need to look at how did we fare with SARS-CoV-2 and with this pandemic. And I attended a meeting last week in Bellagio, organized and co-hosted by WHO and the Rockefeller Foundation on the principles of pathogen sharing. And Dick Wilder, the former general counsel of CEPI, put it very simply after a 20-minute presentation by somebody from the CBD Secretariat. He said, basically, we dealt with this in the way it should have been dealt, which means nobody bothered. George Gao from the China CDC put up the SARS-CoV-2 genome on the GSA data bank on January 10. Actually, Peter Bogner told me, no, it was January 9, because he lives in California. And therefore, for him, it was very early. This was amazingly rapid, and this has happened throughout the pandemic. You know, when you look at what happened to Dr. Oliveira, who put on the Omicron genome, again, in rapid real time. Next day, they got slammed with the travel restriction by the UK, which is not quite the way you want to incentivize people to do it. But therefore, in my view, unhindered immediate access to pathogens is crucial. And in my view, we really need to differentiate between the objectives of the Convention on Biodiversity. I'm personally a big supporter of biodiversity, and I do believe that we need to have good conversation on access benefit sharing. I've said more than once, sadly, there's more discussion on access benefit sharing than concern about benefit generation. I've actually seen more companies walking away from natural resource research. And in the normal area, I think this is pretty much accepted, although the US is not part of the CBD, as we know. But in the area of pandemics, in the area of pathogens, most people I know want to eradicate pathogens. Most people who I know want to put public health first. And I recall a discussion with the late Pete Salomo, who was very concerned and said public health should override, economic considerations. And when we look at what happened in this SARS-CoV-2, two of the things which really worked well among lessons learned is the innovation ecosystem delivered, whether it was academic, biotech, innovative companies, or partnership between innovative and developing country manufacturers. Second, the immediate unhindered access to pathogens. And it's amazing that basically a cooperative of scientists, GISAID, how crucially important they were. They were overwhelmed, of course, and John, you mentioned, the scaling up of sequencing, and I do recall a call I got from Peter Bogner early on, who was really panicky because his IT system was close to absolutely collapsing, and I had to pass the hat around among some companies who helped him to scale up with some in-kind support from quite a number of people. Therefore, I think protecting global health should override ABS considerations. And we also need to see we have had game-changing changes in vaccine development. In the influenza sphere, by and large, you need biological samples. For mRNA vaccines, you need genetic sequences. You need DSI. That's why I'm really concerned about the discussions on inclusion, automatic inclusion of DSI in the Nagoya Protocol and CBD, because we really must be sure we have areas which we need to improve. And as you know, Emma, we are co-hosting with CEPI and Chatham House and the African CDC a lessons learned conference at Chatham House in 2 weeks' time. And one of the lessons learned is we need to do better on equitable access, equitable rollout. Too easily, people forgot the initial allocation principles of WHO, 1% of the world population frontline healthcare workers, 8% actually people above 65. Nobody ever bothered to really pursue that. We really need to do better, and we also need to feature in that vaccine development is risky. 3 of the 4 largest vaccine manufacturers pre-COVID have never come up so far with the COVID vaccine. Therefore, we need to build on the challenges of closed borders. Modi shut the Indian border for exporters on April 1, 2021. The US didn't allow exports till July last year, even President Biden, not just President Trump. And therefore, I do believe, and we do have a discussion in the industry, how can we accommodate the need for the developing countries for more equitable distribution? And with that, I'm closing. Look forward to the discussion.
Thank you, Thomas, and you are more than forgiven since you were bang on time. So we're still on track. I'm going to introduce my last speaker now, and that is Catherine McCarthy, the Regulatory Compliance Manager at the Wellcome Sanger Institute. Catherine, as an academic institution which regularly seeks to access pathogens in many different countries, what are some of the things which could be improved? What have been the main hurdles, and what kind of timelines and obligations are required?
Thank you. And just lastly, thank you again for the opportunity to discuss this topic that is obviously of such high importance with this group. The Wellcome Sanger Institute is essentially focused on leading understanding through generating sequence data and genomic sequence information. And so it is really the bread and butter of what we do. We generate data, we analyze data, we provide that to the scientific community, commercial and non-commercial, to lead to innovation. A large part of what we do is around pathogen-related research, pandemic and otherwise. And it's heavily reliant, if not completely dependent, upon global collaborations and consortia. And so the bidirectional sharing of resources and data is our day-to-day work. It's therefore, our view that the unimpeded or unrestricted access to both data and genetic resources is critical for these collaborations to continue functioning and for them to realise their potential, to reach the aims of the projects that they're working on and to lead to then global health innovations and development. Of great importance for us at the minute and in the future is genomic surveillance, the real-time generation of data and the sharing of that data back to the countries for the samples that have originated. The key is in that phrase. It has to be real time, and so you need to interpret it that any delay is too much of a delay. The main focus for us is informing public health bodies and monitoring systems in those countries. So it's a very much targeted benefit, one that the entire world can then share. In my capacity and in my role, I think I'm quite lucky to have a little bit of an objectional view of this and of what actually takes place and how we deal with it. And so I'm going to talk through some of the challenges that we face. And I do think that challenges can be felt on both the provider side and the user side, although obviously we will lead to the bigger questions later on. So some of the challenges that we observe in ensuring that we comply with access and benefit sharing legislation globally from whatever country genetic resources originate are, I've lost myself, where am I with? As I say, on both sides. So the ones that you're all familiar with are likely the time delays. And for us, the issue with that is it's the unpredictability and the varied timeframes that these can take. It makes it very difficult to plan around in any capacity, really. Next up, the absence of legal certainty can be felt in some countries with ABS legislation in place or not. And in times as well, a disconnect between different ministries, different procedures within a country just leads to further confusion on both sides. Unfortunately, again, that adds to delays. More overarching all of this is political instability, is a fact of dealing with countries globally. And this, around with the government changeover and the disruption that does actually cause to any procedure, I'm sure, but in this context, ABS procedures and processes is really disastrous. In cases there have been a complete rechange of government personnel starting from scratch, and these are months and months of negotiations at times. So the root cause really, though, I think, or a root cause really comes down to resource, both with manpower to put these in place, to implement the laws that have been set down. And that's a real a real stickler, you know, that you can't move forward really without that resource, and that's the real cause of a lot of our problems. Some of the smaller challenges on the provider side that again add to the time delays and the costly side of that as well, but are less invasive, are cultural norms, ways of working, small things that although are not restrictive, they also are not very surmountable either. So small things like having institutional stamps sounds very small, but that can cause weeks of delays by trying to describe the situation in our country in comparison. And the lack of what that holds in terms of legal standing for us. So on the flip side, on the user side, there are some challenges there also that I think we can improve upon as a community. One is awareness raising. We are still in a position where that needs to be focused on, and all to be able to gain the same understanding, a level of understanding, and same interpretation of these things, because that's a real challenge for us on the ground, day to day. Although there are time delays felt by the processes, of course, the time delays towards getting to an understanding to move forward can be almost equal. Similarly, to us in the UK, for example, where we are, these situations and challenges are felt by our partners in the countries that we are working with. Is that me or am I good?
That is, but carry on.
Sorry, very, very quickly. Not at all. And can be felt even more so with the lack of resource and perhaps legal expertise that these negotiations do need. And finally, to wrap up then, the process of academic research is something that needs to evolve, I think. Funder applications, funder timeframes, they all could be adapted to include the necessary timeframes for these things to be put into place. And ABS is one of many. You know, there are human participant ethics, things like that when you're collecting samples and conducting research in other countries that all take similar amounts of time. And unfortunately, this is one more to add to that. So on balance, I should say that there are procedures that work and that meet the aims of access and benefit sharing principles. But I think the big question is whether they should apply to pathogens in an animal and human health setting. Thank you.
Thank you, Catherine. And we still have quite a good amount of time for questions. So if anybody has any questions, please raise your hand. I'm happy to fire a load of questions, but I want to give over to the floor first. Any questions? Oh, yes, go ahead. If we have a microphone, if you could please say who you are and what your affiliation is before you ask your question, and whether it's directed at a particular panelist or everyone in general.
Hi, Christoph Fraser from the University of Oxford. I've been involved in several consortia, and I feel we've made huge amounts of progress in terms of academic data sharing of pathogen sequence data in the last couple of decades. So we've progressed in HIV and other hepatitis viruses, and I laud the progress being described here. I think we do need to be, or I'd like to ask the panel's view on mitigating some of the real concerns that people have now, which I feel may make us go backwards. So, you know, in declaring with our collaborators in for example, in Uganda or Zambia or South Africa, if a new severe COVID variant was discovered tomorrow, there would be disincentives to sharing those data. Nationally, there would be severe costs to travel. The new vaccines would probably not be distributed to these countries in time, and the financial benefits of developing the new vaccines would not be shared with those institutions or with those governments. That's the situation we're in, and the pandemic has made this much more acute. So what do the panel agree that these disincentives exist, and what sort of political or financial systems could help mitigate them through insurance or greater equity?
Thank you. Who is it? John, you look interested. in taking that on first. I'm sure several of our panelists have something to say about that. But John, why don't you start?
I think this is a very difficult one. I think we have to recognise that, you know, this is for a global good, and the disincentives of restriction of travel is a political event that happens, that you actually have to ask, why does that happen? And then you might recognise that actually it was always too late by the time you knew about it. But this needs further investigation, and the kinds of response now should be more able to cope with that kind of response. Early on, when there was no vaccine around, you might well say that that closing borders, even late, is better than not closing them at all. But in the current environment, I think we'd have to say that the global good would say that this is not, that kind of disincentive is politically unacceptable, and I think it's the politics of that rather than the pathogen sharing, gene sequence data sharing, etc. That's the problem there. It's just, I think the ground has changed so that the response, I think, should be different, but I cannot tell you that it will be different.
Thank you, John. I'd like to bring David Heyman in here, that it seems that this is a discussion of something that is not the Nagoya Protocol that's getting in the way of pathogen and information sharing.
Hello? Is it on? Yeah. Okay. Yeah, thanks, Em, and thanks, Christophe. You know, the global community tends to make decisions in Geneva and then provide them to countries and to scientists and to all those people involved in this data sharing activity. It's time that we start to think about getting together the groups that really are in the countries, including the scientists, including the ethicists and those people who need to work in countries, and let them understand the issues and feed into a global mechanism, rather than having it come out of the World Health Assembly in Geneva, which is some place that makes a decision. So in order to really, and I think Jacqueline said it quite well, in order that we really can begin to understand what is possible and what needs to be done, there needs to be education at all levels. And that education needs to include getting together of scientists. I know they get together in many countries to discuss these issues, but in many they don't. And so if the decisions on data sharing and how it's done come from below upwards, it's going to be much more effective in the long run in making sure that there's a consensus developed. However, as John said, political decisions are political decisions. And countries decided not to use the IHR to do their risk assessments. They decided to do them themselves. And so is the IHR something that will continue in the future, at least the recommendations on travel? Other recommendations are really important, such as strengthening global national capacity. So these things all need to be addressed in an eventual new mechanism, but that mechanism hopefully will come from the bottom up and not from the top down.
Thomas, you look like you're ready to weigh in on this.
I think there are two elements. One is, I think there's a more or less consensus that we need more investment in surveillance and data gathering. And when I look at how many countries have now reached out to GISAID, for example, to help them with in-kind support, how many initiatives, be it from Welcome, the Gates or others in terms of data sharing, it is important. The issue of travel restrictions is a delicate one. Having read Woodward's book, latest one, which starts with about 40 pages on the pandemic and the slow response of CDC, having read Mike Lewis' book recently about premonition. In a pandemic, early, you had only non-pharmaceutical interventions. And of course, travel restrictions were one of them. And I'm a little bit, puzzled how those down-to-earth restrictions, which were drawn on the lessons from the Spanish flu, basically developed by Rajiv Venkaya and Richard Hatchett and their team, in the meantime already dismissed, because there's a balance between public health and, of course, economic interests. But I also want to say we need to work on a more equitable rollout to the highest risk populations. And when I look at even now in the current pandemic, which is still ongoing, but the issue is not the 70% vaccination. The issue is the 100% of the vulnerable. And when I look at vaccination rates of people above 80 in China, it's mind-bogglingly low. And it raises questions about what are the reasons behind it. And that exposes the whole world to future risk. But we also, I think, from our industry, and that's what I'm discussing right now, we are involved in many initiatives on better geographic diversity and local manufacturing. For example, looking that the US didn't allow anything out, India cut its border, dramatic consequences, in my view, for the confidence in Indian vaccine manufacturing, which was the vaccine manufacturer for Gavi for the last 20 years. But now I think Africans realize we can't rely on that. Even if all of that or some of that works, I think it would be good if innovative vaccine manufacturers would be willing to commit to put aside part of their capacity for use for the most vulnerable in developing countries. In order for this to work, you need, for example, a Matt Hancock, Mark III, because he is no longer Minister of Health, except that a UK or US or Germany need to collaborate in order to allow the exports of this, putting aside part. And you need a financial intermediary fund able to purchase upfront. So because COVAX was really handicapped not having the money. That's my perspective.
Thank you, Thomas. We're getting towards the end, but I do want to fit in more questions. Are there any more questions? Yes, please go ahead. Please remember to let us know who you are.
Hi, my name is Shaz Khan. I'm an independent consultant in the educational sector. I have a question with regards to the pathogen sharing information. In the Swiss epidemic law, it's specified that a pathogen can be man-made or from nature. And my question is it easier to get the pathogen information from when it comes from a lab? Is it controversial getting information? Because obviously there's a whole layer of complications with that. And is there an instrument that could be incorporated in a future WHO pandemic treaty which obligates all institutions working on pathogens to make that information available? Thank you.
Is there an audience comment that's related to this? Go ahead.
It's not related, but I want to just raise a comment, analysis, point of view. Yeah, shortly. Yeah, about Riyad Bazia. I did short term as a consultant with the UN, and I'm working in this sector since a long time. Yeah, sorry. Yeah, just want about the principle itself, ABS, access and benefit sharing. It is principle itself. If the Framework Convention, CBD, adopt additional protocol in Nagoya City on behalf of this principle, it is, yes, legal, yes. But if we talk about a crisis, we talk about a crisis since a long time in WTO, in UNFCCC. Yes, it is a crisis because negotiation didn't be achieved. UNFCCC, because the negotiations were stopped. We didn't reach to adopt another protocol than Kyoto Protocol. So what I want to just raise, ABS principle itself, even those countries didn't ratify this protocol, we can be understable, we can have co-benefit, cooperation, but doesn't mean necessarily those countries should ratify or should not ratify the ABS protocol and Nagoya Protocol. Thank you.
Okay, thank you. We're just going to get to the question.
Yeah.
John, thank you for that comment. John, if you want to answer the question.
Can you just need the microphone back there, but just by clarifying what was perhaps meant by the lab versus, I mean...
Is there a difference when you're getting pathogen information from a lab as opposed to when it's in nature? Obviously, because in the Swiss law, I'm saying that there is recognized that pathogens can be man-made, and there's obviously there are accidents that happen.
Well, we can use gene synthesis, like, for example, the gene synthesis being used for, as David was saying, for the mRNA, and Thomas was saying for the mRNA vaccines. And so that is the concern there, really, is that is that's sort of man-made information generated from the original pathogen gene sequence data that was shared so rapidly by China, which is in an exemplary fashion. Ultimately, though, that is outside of the current it's outside of the current ABS as the treaty goes, but it doesn't necessarily means it's outside of the national legislation as implemented in particular countries. So in Switzerland, I think that it's fitting much more along the lines of what the treaty says currently. But if the treaty agrees in months' times or whenever this is going to be, it could be a couple of years. But if the treaty agrees that the gene sequence data are also subject to the similar access and benefit sharing, then that's included in the treaty. I don't know if that means the treaty has to be re-signed up to. I doubt it, because I think this would be a modification of the treaty by a footnote or something rather than a new treaty. And therefore, I think that the Swiss situation is currently right. It is easier to deal with stuff that's generated, information that's generated in the laboratory, and sharing those is much easier. But we're on a moving staircase on this, that I think that this will be seen as a way to bypass access and benefit sharing, and therefore I think the parties will not go along with it. Sorry, that's a horrible thing to say.
Thank you. Thank you.
Thank you, John. I think we have time for one more question here in the front.
I hope I don't confuse you more by asking this. I find this, as a journalist and someone who worked at WHO, one of the most complex and nuanced issues that we confront. So I'm still learning myself about it. But what you just said is that the CBD is possibly going to consider genetic sequences as part of the treaty, meaning that benefit sharing them would have to be incorporated somehow. The protocols that you go through right now for actual pathogen examples would also have to be gone through for benefit sharing of genetic sequences. Okay, the other question, which seems to me a bit to be perhaps the elephant in the room, is I'm imagining that from the developing countries' perspective, they're saying, well, once the pharma industry gets these samples freely and it's open access, then they go and make a lot of profit out of it. And you've been talking about equity, which is of course important, but going before the equity, the whole issue that we were seeing raging for months about at WTO about open access to copyright, trade secrets, this kind of thing. They're probably saying, well, if pharma wants open access to these if they want to have open access to our pathogens, then we should have open access to their know-how on the patents for the vaccines. And that to me would seem to be a core issue. Maybe Thomas, you can say something about that. Sorry to put you on the spot, but I'm just trying to go through the logic of this and see what are the real political drivers here.
I think John is gagging, and then we'll go to David
I think
and Thomas.
I think this is super
no,
questions.
this is super.
We're going to hand this around.
This was my wrap-up question.
We're going to go into your lunch break here. I have to declare an interest before answering this. I'm co-chair of the Scientific Advisory Council of GISAID. Now, GISAID is one of the mechanisms in which the gene sequence data are shared. And this is the one with 10.5 million virus sequences in there, as counting of last Thursday. Now, the point about GISAID is that the gene sequence data are shared under a data access agreement, and the data access agreement requires collaboration with the generators of the data. And also the sovereign rights are not lost, and the GISAID is open access, but it's identified open access. It's not public domain. And so that if you put your gene sequence data in GISAID, this is why I had to declare an interest, right? If you put your gene sequence data into GISAID, it is still your gene sequence data, and you still own it. So I just need to clarify that point there, so that that's, I think, what
You're not giving up your negotiating rights by
That's right. That's right. You're not giving up your rights, but I've just done the first part. There's much more than that. Well, the first gene sequence data was put on you need to differentiate between open access and public domain. They're not the same. The first gene sequence data, which didn't come from George Gao's laboratory from China, but came from Wuhan and Shanghai, I think, that was put into public domain database with the help of Eddie Holmes in Australia. But the subsequent stuff and almost all of the rest of the stuff is in the one where you have not lost your ownership of those data.
Thank you. David, what's your take on this?
CBD, there's been a precedent set for seeds, as you probably know. And with seeds, the genetic sequence is what's important, and the genetic data is important. And that can be taken by seed producers from the database, which is held by the FAO. And they attempted to set up a benefit sharing in that if a company took the seed genetic information, they would then, if they put their technology into the public domain, there would be no charge to the FAO for a sustainability fund or an equitable fund. But if in fact they put intellectual property on that, then they had to pay 10% of their revenue to the FAO. This was a mechanism which was tried after the CBD was first set up, and I think it's what John's referring to. A precedent has been set, and they will be looking at this now for organisms. So it's not such a simple issue, but it's an issue that is still under development.
Thank you. I'd like to invite Thomas, who actually, IFPMA is our host for this event, to make some closing reflections, including addressing that issue. But if you could also clarify for me, are there moves afoot to bring in the data into the Nagoya Protocol? There's this working group that's reporting at the end of June, and by the end of the year, we're going to have something. Is this a theoretical threat of fear that we have, or is there something real going on that seems to be parties that are gunning for that? So just to give us a bit of perspective of how real this threat is, or is it a theoretical thing based on precedent and what's going on in other areas? And then also if you could share your closing reflections so that we can eat.
Be short and crisp. The danger of inclusion of digital sequence information is real, and I think we are among the culprits for holding out, supported by Japan and hopefully a few others, because, you know, even senior WHO folks agree with me. We disagree with Thomas in many elements, and Nagoya is right. Pathogens in Nagoya are absolutely in conflict with each other, and public health should override, you know, economic considerations. The issue in terms of, you know, but there are companies making a benefit. Have a look at the recent WIPO annual report, or have a look at actually BARDA, for example, invested quite heavily in Moderna. Pfizer, by the way, never wanted BARDA money because they said we can afford to risk 2 billion and lose it. Most companies who had vaccine projects lost it. You know, there were 300 plus vaccine development projects with Sanofi, GSK, Merck & Co., and many, many others, CureVac, and Ingelheim is not in the human health vaccine development. You know, most of these projects, and many companies, for example, offered collaboration to fill and finish or do drug substance. And I know companies who also had their arms twisted by a government or the other, for example, Germany, and nothing came out of it. Therefore, the issue, I think, in terms of public health should override. And for us, for God's sake, you know, Pfizer, BioNTech, Moderna, J&J, AstraZeneca, they saved our skins. Because the reason we are now at the end of the pandemic is that they really, you know, they came up with the vaccines. And if you would put it a little bit in a blunt way, if I were a populist, which of course I'm not, I would say China gifted the world with SARS-CoV-2. And this cost the global economy, numbers from Gita Gobinath from the IMF, $375 billion per month for more than a year. And then based on Nagoya, you get an invoice from Beijing we now want royalties on your vaccines. You know, in the pathogen area, I would say that's pretty insane. And we need to have common sense prevail. That does not mean that we need to address the equitable rollout and we need to overcome the challenges that were there. But basically, nobody could, you know, patent SARS-CoV-2 because that was in the public domain. What you can, but fortunately we have not one vaccine. We have now, I think, 9 or 10 officially approved by the WHO for emergency use license. And I think we really need to have an honest debate about how do we make sure that we live up to what's in the Biodiversity Convention. And seeds I would include in there, you know, some of the tree-derived or natural resource-derived, when you have flavor and fragrances or oncology medicines. That's where we need to have a debate about access benefit sharing. Whereas in the area of pathogens, we really need to make sure that what worked well in this pandemic will continue to work well in future pandemics. And with that, I close.
Thank you, Thomas. That's a great close. And so I'm going to draw this to a close now officially. But outside there is food and drink and further access to our very eminent speakers. If anybody wants to follow up on any of those points or ask more questions, there's an opportunity there. So thank you all for joining us for this very important and scary discussion, if I may say so. And, you know, we are very lucky that this issue has not come to a head during this pandemic, because it'd be interesting to see what might have happened would this have been post the latest Nagoya negotiations. But anyway, something to think about, and on to outside. Thanks so much.